Under the Needle, where acupuncture meets anatomy. Today, we're exploring large intestine 4, one of the most commonly used points in clinical practice. LI4 is located on the dorsum of the hand, in the soft tissue between the first and second metacarpal bones. More specifically, it lies within the belly of the first dorsal interosseous muscle, which becomes prominent when the thumb and index finger are brought together. To locate the point, ask the patient to gently pinch the thumb and index finger toward each other. This activates the first dorsal interosseous, creating a visible and palpable muscle bulge on the dorsum of the hand. LI4 is found at the highest point of this muscle belly, just distal to the midpoint of the second metacarpal bone. When the pinch is released, the point remains identifiable as a soft, slightly tender depression within the muscle tissue. After locating LI4 in the belly of the first dorsal interosseous muscle, confirm the point by palpation. Using the pad of your thumb, apply gentle perpendicular pressure into the muscle tissue. The point often feels slightly tender or resistant compared to surrounding tissue, especially when the muscle is engaged. Palpating with a slow, sinking pressure helps distinguish muscle belly from adjacent bone. Needle angle. The needle is typically inserted perpendicular to the skin surface or with a slight oblique angle directed toward the second metacarpal. A perpendicular approach allows direct access into the muscle belly, while a subtle oblique angle can be used to follow the muscle fibers and avoid unnecessary contact with deeper structures. Needle depth. Insertion depth generally ranges from 0.5 to 1.0 cm, depending on the patient's hand size, muscle bulk, and tissue density. Advance the needle slowly until resistance from the muscle belly is felt. Depth should be sufficient to engage muscle tissue without contacting bone. If the needle meets hard resistance early, withdraw slightly and redirect. From an anatomical perspective, LI4 is positioned within a densely innervated and well-vascularized region of the dorsum of the hand. The point overlies the belly of the first dorsal interosseous muscle, an area supplied primarily by branches of the radial nerve, with contributions from adjacent sensory fibers innervating the dorsal hand and fingers. This concentration of neural tissue contributes to the point's sensitivity on palpation and its strong afferent response during needling. Superficially, the region contains small venous networks and connective tissue planes, while deeper layers are composed of tightly organized muscle fibers and fascia capable of efficiently transmitting mechanical force. Stimulation within this muscular, fascial interface influences local neuromuscular tone and sensory signaling, which helps explain the point's consistent local effects and its broader distal clinical applications. Because branches of the radial nerve course near this region, needle advancement at LI4 should be slow and controlled. A dull, spreading sensation or localized heaviness is an expected response when the muscle belly is appropriately engaged. From a neuroanatomical standpoint, LI4 functions as a powerful peripheral access point into cervical spinal segments involved in upper extremity and head-neck sensory processing. Sensory input from the dorsum of the hand at LI4 is carried primarily by branches of the radial nerve, which project to the dorsal horn of the spinal cord at C5 through C8 segments. These same cervical segments also receive afferent input from the neck, shoulder girdle, and portions of the upper cervical region, within the dorsal horn. Afferent signals from the hand converge with sensory input originating from cervical musculature and deep neck tissues. This convergence creates a neurological basis for referred and modulatory effects, allowing stimulation at LI4 to influence pain perception beyond the local tissue. In clinical terms, this helps explain why a distal hand point can consistently affect symptoms in the head, neck, and face. Headache relevance becomes clearer when considering the interaction between cervical spinal segments and the trigeminal system. Sensory input from the trigeminal nerve, which innervates the face and cranial structures, converges with upper cervical spinal afferents within the trigeminocervical complex, a functional network linking trigeminal nuclei with cervical segments, particularly C1, C3, but influenced by broader cervical input extending into C5, C8 through internuminal connections. Modulation of sensory traffic at the cervical spinal level can therefore alter trigeminal nociceptive processing by stimulating LI4. Afferent input entering at C5, C8 may influence central pain modulating pathways that intersect with trigeminal processing, contributing to reduced headache intensity, altered pain perception, and improved neuromuscular regulation in the head and neck. This mechanism supports the traditional use of LI4 for headaches, facial pain, and jaw tension while grounding its effects in known neuroanatomical relationships. Clinically, LI4 should be understood not as an isolated endpoint, but as a distal neuromodulatory site capable of influencing cervical and trigeminal pain networks through spinal convergence and central integration. From a traditional perspective, LI4 is a primary point on the large intestine channel and is classically described as a point that regulates qi, clears heat, and releases the exterior. Clinically, it has long been used for conditions affecting the head and face, including headache, sinus congestion, facial pain, and jaw tension. Within the traditional framework, this reflects the channel's pathway, which ascends from the hand along the arm and neck to the face. When viewed through an anatomical lens, LI4's effects can be understood in terms of its location within a dense neuromuscular and facial region of the hand. The point lies within the first dorsal interosseous muscle, an area rich in sensory receptors, proprioceptive input, and connective tissue continuity. Stimulation here generates robust afferent signaling that enters cervical spinal segments and interacts with central pain-modulating networks involved in head and facial sensation. Rather than replacing traditional explanations, anatomical insight provides a complementary layer of understanding. The classical concept of regulating qi can be viewed, in part, as the modulation of neuromuscular tone and sensory signaling, while clearing heat aligns with observable changes in pain perception, inflammation-related sensitivity, and autonomic regulation. The large intestine channel's influence on the face mirrors known neuroanatomical pathways connecting the upper extremity, cervical spine, and trigeminal system. Integrating these perspectives allows for sharper clinical reasoning. Traditional theory guides point selection and pattern recognition, while anatomy informs needle placement, depth, safety, and expected tissue response. Together, they move treatment beyond rote point use toward an intentional, mechanism-informed approach, one that respects classical knowledge while grounding clinical decisions in structure and function. This is just one example of the anatomy we explore. If you want to study all acupuncture points systematically, deepen your clinical understanding, and earn continuing education credits, the Anatomy of Acupuncture Atlas and the full online course walk you through the entire framework. You'll find the links in the description.